Good morning, everyone. Thank you for attending our Grand Rounds lecture. My name is Rahul. I'm one of the Chief Cardiology Fellows here at VCU. I'm pleased to introduce to you a special guest speaker from across the Atlantic, Dr. Mamas Mamas, who will be talking about acute MI in cancer patients. Today's lecture is part of the Natalie and Jack Congdon lecture series. First, a brief history regarding the lectureship. In 2010, Natalie and Jack Congdon established the Natalie and Jack Congdon Visiting Scholar in Cardiology, which enables the VCU Pauley Heart Center attract a number of talented cardiologists. After his service in the Army, Jack helped build the family trucking businesses of Old Dominion Frightline and Old Dominion Truck Leasing. Jack was a proud supporter of the Massey Cancer Center and the Pauley Heart Center. Jack and Natalie passed away about 10 years ago. They had 3 children, and their son John continues to support the Pauley Heart Center as a donor and an advisory board member. Our guest speaker today, Professor Mamas Mamas, trained in medicine at the University of Oxford, completing his clinical training in 2000. He's a professor of cardiology at Keele University and is a practicing interventional cardiologist. Professor Mamas is a board member of the European Association of PCI and an associate editor of Circulation Cardiovascular Interventions. Professor Mamas is the clinical director of the Center for Prognosis Research at the Keele University and leads a group of clinicians and data scientists and statisticians whose research interests focus around the use of routinely collected electronic health data to inform the diagnosis, treatment, and clinical outcomes of real-world patients with cardiovascular disease. He has published over 800 peer-reviewed manuscripts using big data in populations with cardiovascular disease, with a particular interest in studying real-world PCI outcomes. We are grateful for Dr. Mama's expertise on this topic and look forward to learning from him. At the end of the lecture, we will leave time for questions. Please submit the questions via the chat function on Zoom as they arise during the talk. As always, we are pleased to offer both MOC and CME credit for our Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and at the end of this presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloud-cme.com or contact Shannon Winston. I will now turn it over to Dr. Mamas.
So thank you, Rahul, for your generous introduction, and thank you to all the faculty of VCU for joining us today. It's a real privilege. Firstly, I'd like to apologise for the format. We had problems with my computer in terms of slide sharing, so I've actually had to use my slides as a background and sort of stand away from the screen. So hopefully it's not too distractive and doesn't take away from the message that we're going to talk about today. The focus that I hope to share with you is around a group of patients that we're going to increasingly see in clinical practice, that is cancer patients, and really how routinely collected electronic healthcare record data in this group of patients can inform us around the type of care that we offer patients with cancer, with cardiovascular disease, and their outcomes. I have no conflicts of interest relating to this particular presentation. Now, you may say, well, okay, cardiovascular disease, cancer, why are you so interested in it? Well, why do they occur concurrently? And really, there's several reasons why the two conditions can often occur hand in hand. First and foremost, there are shared risk factors. We know that many of the risk factors that contribute to cardiovascular disease also contribute to cancer development, so obesity, smoking, diabetes, and so forth. We also know that many of the pathophysiological mechanisms that contribute to both disorders are very similar, so oxidative stress, chronic inflammation, and so forth. I think the other thing that we must think about is that many of the cancer therapies that we use in treating patients with cancer can also act as cardiovascular risk factors, and many of the complications occurring with these therapies are cardiovascular events. So, we think about chemotherapy, some of the agents, radiation, immunotherapy, hormonal therapy that we'll talk about a bit later. Now, you may also say, well, okay, that's fine. You've persuaded us that, that there is a link between cancer and cardiovascular disease. Why is this important? Well, the reason that it's important is that we're increasingly seeing patients, survivors of cancer with cardiovascular disease. This is some data that we published recently in the European Heart Journal Quality Care Clinical Outcomes, looking at 42 million admissions with a cardiovascular disease in the United States. And you can see in the general population, there is a decline over around 15 years of around 10% or so for hospital admissions with cardiovascular diseases. Whereas in the cancer population, you can see a marked increase of close to 25%. So it's certainly a growing problem that we're seeing in this patient group. This is some data that I think is quite interesting, and it's looking at cardiovascular events as a function of years from diagnosis for cancer. And you can see that there's a real spike in cardiovascular events within the first 18 months to 2 years following diagnosis of cancer. And again, that sort of brings or supports the hypothesis that perhaps many of the cancer therapies that we're using can increase the manifestation of perhaps prevalent cardiovascular disease that many of these patients have in the background. Now, with cancer survivorship, we know that patients that do survive following cancer treatment, often their risk from cardiovascular disease exceeds their risk of cancer. So if you're a 70-year-old woman and above diagnosed with breast cancer, your risk of dying from cardiovascular disease is actually greater than your risk of dying from breast cancer. And you can see that there's variable duration in the timings of when your cardiovascular risk exceeds your cancer risk. So for colorectal cancer, in patients 60 to 79 years, within 8 years of diagnosis, your cardiovascular risk exceeds your risk from colon cancer. And you can see it varies according to, number one, cancer type, and number two, the age of the patient. So as we're getting better at treating patients, their survivorship is increasing, but their risk of cardiovascular disease is increasingly overtaking their risk from mortality from cancer. And the cardiovascular phenotype of different cancers varies. We've published data from the emergency department. We've published data from hospital admissions. This is hospital admission data. And you can see that, for some cancers, such as colorectal cancers, myocardial infarction is the commonest presentation as a first cardiovascular event. Whereas for other cancers, such as lung cancer, it's AF. For patients with hematological malignancies, it's heart failure. And I guess that relates to a number of factors. Number one, the risk factor profile of the types of patients that get these malignancies. And number two, the types of therapies that we use to treat these malignancies, and particularly their risk-benefit profile, particularly in relation to cardiovascular side effects. Now, you may say, well, okay, you've persuaded us that this is a problem. How much is coronary heart disease or ischemic heart disease a problem in terms of mortality, cardiovascular mortality for patients with cancer? So we published this piece of work through analysis of the CDC Gov dataset from the US. And the first thing to say is that ischemic heart disease as a cause of death in patients with cancer is the number one cardiovascular cause of death. And the other thing to say is that between 40 and 60% of patients that have a cardiovascular death will die from ischemic heart / coronary artery disease, depending on cancer type. The second thing to say, and you can see this in the right-hand side of the panel, is that there hasn't really been much of a change in that. There's been slight reductions, but overwhelmingly, ischemic coronary heart disease up to 2019 is the most important cardiovascular cause of death in patients with cancer. The other thing to say, and this is a paper, it's not on the slides, it's a paper that we published this week, is to say that many of the disparities that we see in terms of cardiovascular mortality in the general population are evident in the cancer population as well. So we see that certainly there's very much a rural versus urban disparity. So patients with cancer are more likely to die from cardiovascular disease if they live in rural areas than urban areas. And certainly we report in the paper that we published this week racial disparities. So if you're a Black American, you're far more likely to die than a white American. So when we think about disparities in cardiovascular care, it's really important to think about disparities in relation to cancer diagnosis, but within that population, also remember that we're having significant disparities both in terms of sex, rurality, and race. That's a really important point I'd like to emphasize. Now, the next thing is, why do we have an increased risk of myocardial infarction in patients with cancer? And we've already discussed issues around sharing of risk factors, therapeutics, radiotherapy, the fact that cancers are pro-inflammatory sedate and prothrombotic. But we know that certain drugs can cause vasospasms, they can induce arterial thrombosis, they can cause plaque rupture. Certainly there's issues around coronary embolism or compression of the coronary artery by the tumor. And all these factors predispose or increase the risk of ACS in cancer patients. And I've shown you data already that this is particularly evident in the first 18 to 24 months of diagnosis with cancer. This is some data from the 2016 position paper on cancer treatments from the European Society of Cardiology. There are more recent tables, but I chose to show this one because the more recent tables in the latest 2022 guidelines were a bit of a nightmare and it was really small to see. But you can see that many of the agents that we use in treating cancers are associated with, quite significant risks from the cardiovascular perspective, and in particular from the coronary heart disease perspective. If you want to look at these slides or have these slides, then just liaise with Shannon. She can give you a copy of my slides. I don't have a problem with that. So I'd rather you focus on the talk than trying to scribble down what tables show. So in terms of, and this is not really working, which is a pity, in terms of what we see over time in myocardial infarctions, the way that I've set up the slides is not actually showing what I would hope it would show, because it's not showing animations. But what I'd like to describe is that cancer is becoming increasingly prevalent in patients with myocardial infarction presentation. So that was the first panel that's hidden behind here was meant to show. So actually, in contemporary practice, about 1 in 10 patients presenting with a myocardial infarction will have either a current or a prior history of cancer. Now, one of the things that is really evident when you look at administrative data, and this is an analysis of administrative data from the US, is that patients with cancer are much more likely to be medically managed than their non-cancer counterparts. They're much less likely to get coronary angiography, and they're much less likely to get PCI. And you can see the right-hand side of the panel that translates to worsening mortality, worsening MACE, and worsening bleeding complications compared to the non-cancer population. And the other important thing to show is that the prognosis very much depends on cancer type. And again, the animations aren't working, so I'm just going to run through the data. You can see that certainly in terms of all the cancers, they're associated with worse prognostic impacts compared to the non-cancer patients, but this is particularly evident for some cancers such as lung cancer and colon cancer, whereas the prognostic impact of, say, prostate cancer is much less so. And again, in terms of major bleeding complications, the prognostic impact varies according to cancer type. And the other thing to say is, and again, it's important, it also varies according to stage of cancer. So you can see that for some cancers, such as prostate cancer, breast cancer, the prognostic impact when you're having a heart attack actually isn't evident in those without metastases. So if you've got localized prostate cancer, localized breast cancer, in a myocardial infarction, these cancers do not have a prognostic impact. It's only when you have metastases. That's in contrast to things like colon cancer or lung cancer, where these conditions do have an independent prognostic impact in the setting of myocardial infarction. This is data from the UK Heart Attack Registry, and this is quite important data, and I'll explain why. And again, this is a problem with animations. What the first slide was going to show, which I can't show because of animation, is that heart attack care in the UK is inferior in cancer patients compared to non-cancer patients. And if you look at all the quality metrics as defined by European Society of Cardiology, being managed by a cardiologist, being admitted to a cardiology ward, having an inpatient echo, door-to balloon times, referral to cath for NSTEMI within 72 hours, for NSTEMI with a GRACE score of over 140 within 24 hours, prescription of potent P2Y12 inhibitors, receipt of cardiac rehabilitation. All those metrics are worse if you're a cancer patient presenting with a myocardial infarction than if you're not a cancer patient. And therefore, your outcomes are much worse. You can see that your 30-day and 1-year mortality, once you've adjusted for differences in risk factor profile, are increased. So a 40% increase at 30 days and a 200% increase at 1 year. And you may say, well, okay, how about if the patients die in hospital from their cancer? Well, even if you exclude these and just look at a landmark analysis on those that survive to discharge, you can see that 30-day mortality is double, 1-year mortality is threefold. Now, you may argue, well, okay, but death isn't really a good surrogate. They may be that, you have the competing risk of cancer, and perhaps that's why these facts are increased. Well, you can see that actually at 30 days, 2/3 of deaths following a heart attack in the cancer population are cardiovascular deaths. And so, these worse outcomes aren't explained by the fact that these patients have cancer and are dying from cancer. These are cardiovascular deaths. And even at 1 year in cancer, within patients with active cancer, about half of their deaths after a heart attack are cardiovascular deaths. And so clearly we are undertreating this population. We're not giving them evidence-based therapy. We're having worse outcomes. And the majority of deaths, certainly at the earlier time points, and up to half of all deaths at the longer time points at 1 year, are cardiovascular in origin. Oh, and this actually, so I got the slides the wrong way around. So this is the data in terms of the quality metrics as defined by the ESC. So in terms of for STEMIs, reperfusion within 12 hours, door-to-balloon times of less than 60 minutes, less than 120 minutes, assessment of ejection fraction, P2Y12 inhibitors, DAPT on discharge, high-intensity statin on discharge, ACE inhibitors for those with left ventricular systolic dysfunction, beta blockers with those with significant left ventricular systolic dysfunction, referred to cardiac rehabilitation. Every one of those metrics is worse if you have cancer than if you don't have cancer. And that's a really important message, really, that I hope to bring across. Some of the outcomes in this population are inherent because they're higher risk, but some of the outcomes that are worse are related to the fact that we're not treating these patients optimally. And it's not just mortality. If you look at, say, heart failure readmission, same data set. This is a paper in JACC Cardio-Oncology that hopefully will be coming out. You can see that if you look at the cancer group overall, there's an increased risk of readmission with cancer for heart failure after a STEMI compared to the non-cancer population. And it seems to be particularly evident in the colon hematological cancer subgroups. These are not significant when you look at subgroup analysis because the event rate is quite small and it's just underpowered, as you can see from the relatively wide confidence intervals. And the other thing to say is that we often worry around ischemic versus bleeding complications in this cohort of patients because we know that cancer is a prothrombotic state, but we also know that cancer can increase the risk of bleeding complications by virtue of the effects of, the cancer type. So GI cancers, we know, are at increased risk of bleeding complications. Coagulopathies, thrombocytopenias, anemias, all increase the risk of bleeding complications. But when you follow these patients following a myocardial infarction and adjust for differences in baseline covariates, you can see that actually the risk of reinfarction is not so evident. It's bleeding at 1 year and earlier time points, and it's irrelevant of whether they receive a PCI or not. The major risk is not ischemic complications once you've adjusted for baseline covariates. It's really related around major bleeding complications. And again, I'm going to show you data later on in the grand round that suggests that a lot of this depends on cancer type, as one would expect. Now, I think part of the other reason why we don't really treat patients following the heart attack optimally, and it could be the same for AF. I mean, we've published papers in AF, we've published papers, in other fields around cancer, is that often, in the landmark ACS randomized controlled trials, patients with cancer are excluded. So if you look at all the primary PCI RCTs, cancer patients were excluded. If you look at the various antiplatelet trials, unless the HBR trials, again, they were excluded either directly, it explicitly says cancer is an exclusion criteria, or indirectly because they have factors such as excluding non-cardiac comorbidities with life expectancy less than X years. So Horizons AMI, pretty much most of the primary PCI trials will exclude cancer patients by virtue of this, or other trials will, like Triton, will exclude them by virtue of the fact that these patients are at increased risk of bleeding complications. So there is an evidence-based gap in these patients from randomized trials, at least. And again, this was meant to be animations coming round as I talked along the slide, but unfortunately it's all appeared as one. It's a background slide. And really, some of the concerns that operators have in offering invasive strategies to patients with cancer are several-fold. I mean, number one, these patients are often multimorbid. And so, operators may think, particularly for NSTEMIs, that they may be better managed medically. Many of the cancer drugs that we use and the patients may actively on are associated with increased risk of thrombotic sequelae. And so many operators are put off by these. That there's uncertainty of benefit. We know that these patients have cancer, the risk of cancer-related mortality is high. Perhaps there's a wrong perception of what's the benefit of giving these patients treatment, although I have shown you that the majority of deaths at 30 days are cardiovascular following an acute myocardial infarction in the UK. There may be hematological problems like thrombocytopenia, anemia, which puts operators off undertaking invasive procedures, or the issue of malignancy-associated coagulopathy. And also, technically, it's often more challenging in doing these sorts of cases, particularly after radiotherapy, where there's lots of fibrocalcific disease. It's very diffuse disease as well. And perhaps operators are concerned about, how optimal their result is going to be, which really then means that these patients are treated medically. This is data looking at bleeding and thrombotic risks in cancer patients undergoing PCI. This is a Mayo Clinic single center analysis with 5-year data. And what this shows is that these patients are complicated in that they have an increased risk of bleeding events, but also increased risk of thrombotic events, as evidenced by MI and stent thrombosis. But again, they didn't look at cancer patients individually. It's a pooled analysis of all cancer patients, which we know behave quite heterogeneously. In terms of how common are we doing PCI in patients with cancer? This is, again, data that my group published in the European Heart Journal, showing that, again, 1 in 10 patients that have PCI in the United States either have a current or a prior history of cancer, and that's increasing over time. So it's not a question of, will I ever manage a patient with a heart attack and cancer? It's more a question of when you will manage them, and you will manage them. And the trajectory is that we will be seeing much greater proportion of these patients, particularly with increased survivorship from cancer therapy. In terms of outcomes following PCI, so a separate paper, we looked at PCI outcomes in patients with cancer versus no cancer. And again, you can see that it very much depends on cancer type. So in terms of mortality, you can see that prostate cancer, breast cancer do not have an increased risk of mortality following PCI. And so there's absolutely no reason to exclude these patients. Nor do colon cancer, lung cancer patients do, but it's certainly a lot more for patients with metastases. So you have to think about, is the patient got metastases or not? And again, the overwhelming take-home message is that these patients are more at risk from bleeding complications than ischemic complications, particularly for some cancer types such as colon or GI cancer. Those patients particularly at increased risk of bleeding complications following a PCI. This is a different paper where we looked at unplanned readmissions following a heart attack and PCI. And again, you can see that the risk of readmission with ischemic events in cancer varies by cancer type. The highest risk is lung cancer, followed by colon cancer. And again, the risk of bleeding varies, but overwhelmingly, it's the GI cancers that have the greatest risk of being readmitted with a bleeding event. This is other data for Lorenz Raber from Switzerland, again, a PCI study. And again, you can see that in terms of total mortality, probably isn't much difference, but in terms of cardiac death and major bleeding, there is a big difference. And it also depends on the timing between your cancer diagnosis and your cardiovascular event. So the greatest risk seems to be how close your MI or PCI is in relation to your index cardiac event. So if you were diagnosed with cancer many years ago, the prognostic impact of a PCI in terms of bleeding or ischemic event is much lower than it was diagnosed much more recently. And that makes sense. We know that in patients that were recently diagnosed with cancer, they're much more likely to be on chemotherapy. They're much more likely to be having coagulopathies or thrombocytopenias or other factors related to their cancer treatment. So, the adverse events really depend on how close the cancer diagnosis was to your acute myocardial infarction. Now, you may say, well, okay, how do we know that PCI actually works in these cancer patients? There is no randomized controlled trial, and that's true. There is no randomized controlled trials. They were excluded in the primary PCI trials. And what we did was try to look at this from a routinely collected electronic healthcare record data perspective. And what we did was propensity score matched STEMI patients receiving primary PCI versus those not receiving it, control patients, and then the different types of cancer patients. And this is the take-home message. You can look at the table, you can by all means look at the paper, but the take-home message is that the average treatment effect or the benefit of receiving primary PCI was similar in any of the groups of cancer, whether it was hematological malignancies, breast malignancies, lung malignancies, colon cancer, as it was with the non-cancer population. So you have as much benefit in this propensity score matched analysis receiving primary PCI if you have cancer than if you don't. This is not randomized controlled trial data. There will never be a randomized controlled trial because I think it would be unethical looking at treatment efficacy of primary PCI in this population. But the data is there, albeit observational. And this is in guidelines now. These are 2022 ESC cardio oncology guidelines, where it's a class 1B indication. The invasive strategy should be offered to patients with cancer with a life expectancy of greater than 6 months. Now, you may say, well, okay, how do I know in the middle of the night whether they've got a life expectancy of greater than 6 months? Even if you don't, I would say offer primary PCI or in these patients. In terms of NSTEMI, you've got time. Unless they've got ongoing pain or dynamic changes, you can certainly discuss with your oncologist the following day or during the day. So I don't think it's as much of a rush. But in primary PCI patients, if they've got more than 6 months life expectancy, give them primary PCI. If you're not sure, give them primary PCI. And again, if you do get these patients in, have a think about what cancer therapy they're on. You may need to interrupt the cancer therapy, particularly if it's one of those like immune checkpoint inhibitors that are known to be associated with the risk of MI. And again, it's something that you can discuss with your oncology colleagues, again, oncology consult. And again, the guidelines say that if you're going to do PCI or treat these patients, then a short DAPT strategy is very much the treatment options. Again, because of the way I'm showing the slides, this hasn't come through, but these patients are high bleeding risk by virtue of the fact they have cancer. So this is the Academic Research Consortium definition of high bleeding risk for PCI, but also by virtue of the fact that many of these patients are anemic, have low platelet count, may have liver disease, liver mets, bleeding bath disease, but also there may be plans for surgery. I see lots of patients in the ACS setting that perhaps, they're planned for colon cancer resection. And so, again, they're defined as high bleeding risk because they're going to undergo major surgery in these patients. And the ESC guidelines most recently are 12-month DAPT for general population, unless they're high bleeding risk, which the cancer population is. And in that case, then it should be 1 month monotherapy of DAPT, and that's a class 2B level of evidence B. Now you may say, well, okay, where does that data come from? It comes from the Master DAPT trial. This was a randomized controlled trial of patients at high bleeding risk undergoing PCI. About half of these patients were ACS patients, half of them were elective, and cancer was an inclusion criteria. So active cancer was defined as a high bleeding risk patient, and about 10% of patients recruited to this trial had cancer and were included. And the patients were randomized at 30 days to either standard DAPT, which was defined as greater than 2 months or up to 11 months, or abbreviated DAPT, where you just do single antiplatelet therapy for 30 days. And the outcomes of the trial are this: that if you look at ischemic events, there's no hit in the high bleeding risk population. You don't have an excess of ischemic events by shortening your DAPT duration, but you have a reduction in bleeding complication driven by BARC2 bleeding. So the reduction in bleeding is about a third. So you having short DAPT regime in high bleeding risk populations, of which cancer is one, is associated with a reduction in mortality. I was the handling editor of a pooled analysis from this and other trials around cancer patients, randomized controlled trials. And it seems that the benefit that is the same in cancer patients, i.e. shorter DAPT in these patient groups. And people ask me, well, does it matter whether it's aspirin or clopidogrel? Certainly in the overall population, again, it's underpowered to look at the cancer population. It doesn't seem to matter. So there wasn't a treatment effect by whether you used aspirin or clopidogrel as your single antiplatelet agent. Now, you may say, well, okay, that's the data for overall population. How do we know this is safe in the ACS subgroup? And there was a circulation ACS subgroup paper from this randomized controlled trial showing that there was no treatment effect. The P for interaction was negative in terms of ACS versus non-ACS population. So in ACS patients with cancer presenting undergoing PCI, short DAPT, 1 month dual antiplatelet therapy, because these patients are at high risk of bleeding complications. In terms of, I mean, I guess this is, old data, and again, I don't know what the US practice is, but in the UK, we've pretty much moved away from bare metal stents. I don't think my cath lab stocks bare metal stents anymore. I don't think I've used one. I'm pretty sure I haven't used one for over 5 years at least. But if if in your part of the world or in community labs that they still do use bare metal stents, I would say don't. This is the leaders-free trial of high bleeding risk patients, and again, this is a randomized trial of short DAPT randomized to either bare metal stents or drug-coated stent, the BioFreedom platform, showing superiority for ischemic endpoints. There's no reason that you should be using bare metal stents in this group. Use one of the platforms that has been validated in high bleeding risk populations, and there are several of those that one can use. And this is the leaders-free ACS subgroup, and again, showing similar sorts of benefit of drug-coated stent versus bare metal stents. Now, the important thing to say is not all about antiplatelet therapy. It's not all about primary PCI. We need to think about other evidence-based treatments. So if you're going to do primary PCI, you should not be doing it femorally in this group of patients. They are high bleeding risk, so go radially. This is a class 1A indication, both in US and European guidelines. I also think that you should be using intravascular imaging. In the latest ACS guidelines from Europe, we have it as a class 2A indication. I would say that in cancer patients, it's particularly important. And the reason why it's important is, we've said that these patients have a risk of bleeding. And I have done cases where, for example, I've done, I don't know, say, a case with pancreatic cancer. I did a primary PCI, great results. And the patient had a huge GI bleed that night. So I had to stop one of the antiplatelets. And so, I've done a primary PCI the day before, and within 24 hours, I have to stop one antiplatelet because they've had a massive life-threatening GI bleed. I could sleep slightly better that night because I'd done intravascular imaging, and I knew that, my stent was well opposed, it had good expansion, there was no malposition, no edge dissection. I've also had cases where someone's undergoing chemotherapy, they've come in with a primary PCI. I've done it, it was a left main. It's not something you discuss with the surgeons in the middle of the night, so I did it. I did a 2-stent approach. I then get a phone call a few hours later from the ward saying, "Prof, this patient's platelet count is 7. And you think, bloody hell, they're on tool antiplatelets. Then it goes down further, it goes down to 3, and then you think, well, okay, I should probably, withdraw one of the antiplatelets. When you've done you've done a 2-stent approach, you feel a lot more confident in doing that when you've made sure that you've performed your procedure optimally with intravascular imaging, and it doesn't, and also we know that thrombocytopenia is associated with increased ischemic risk as well. So even if you continue and hold your nerve, your dual antiplatelets, with single-digit antiplatelet levels, you're confident that, again, you've done as much as you can, your stent's well opposed, you've got a good stent result to minimize the risk of ischemic complications. Again, this is the reasons why we do intravascular imaging. I'm not going to focus too much on this slide because I know that many in the audience aren't interventional cardiologists. And so, probably not going to be relevant to you, but I would say that, you should use it for many reasons. So I think, coming to a close, I want to have some time for discussion as well. So I've sort of planned it to be 40 minutes, this presentation, and you'll probably get bored listening to someone for an hour anyway. I think in patients with acute coronary syndrome, it's not a question of if I will see these patients, it's when you will see these patients. You will see patients with current or historical cancer. It's becoming much more common. I think if you're going to take anything away from this talk, I would say that these patients have as much benefit for PCI as patients without cancer. So you should not be discriminating against these patients. And that would equate for all of the therapies that we offer. Cancer patients, after a STEMI, the biggest cause of mortality at 30 days, 2/3 of all deaths is cardiovascular. Many of these are avoidable if we give these patients, guideline recommended therapy. We are not giving them that. We're not, being as aggressive with them as we ought to be. And that's a really important point, one that I want to emphasize. They are at increased risk of ischemic and bleeding complications, but more so bleeding complications. The ischemic complications, once you've adjusted for baseline characteristics, it doesn't seem to be so obvious. And really, the bleeding complications depend on both cancer type and stage. So you really need to think about that. And your approach to these patients really needs to be considered, particularly in PCI, pre, during, and post. And I think you particularly for the end-STEMI population, you have time to think. You don't need to rush them into the cath lab, particularly if they're low risk. Straight away. Sit down, discuss with your cancer colleagues. The final thing I would say is look what active treatment they are on. What I've often seen is patients getting great care, discharged, and no one's thought, wait a minute, what cancer therapy are they on? Could this have contributed to their presentation? So have a look at that. If you're not sure, get your oncologist or your cardio oncologist involved. So with that, I would like to thank you for inviting me. I'll stop sharing, and hopefully you can still see me. Yes, you can. So I'll change the position of my computer so I can actually see you guys now. So thank you.
Thank you, Dr. Mamas. That was an excellent talk. I think in the field of cardiology, data on cardio-onc patients is very limited. And I agree with you in terms of the lack of representation, RCTs, and we need to learn more about these patients. So great talk, and thank you for teaching us. In terms of the same population, I know in the last few years, we have had a debate on primary prevention, particularly with aspirin and statins, particularly aspirin in the general population for primary prevention has been debated. What are your thoughts on aspirin for primary prevention in the cancer patients? I know these patients have an increased risk of coronary events. At the same time, they have an increased bleeding risk.
Yes.
It can be stratified maybe with, I'm sorry, go ahead.
No, I can't. No, so that's a really, really insightful question. So it's slightly complicated. So we have done work with, say, the Sinai, looking at the predictive effects of coronary artery calcification in this. We published this, I don't know, a year or two ago, with first author was a colleague from the University of Calgary. I was the second author. And what we found is that CAC score predicts cardiovascular events in the cancer population. The slightly other confusing thing is it's not a stronger predictor compared to the non-cancer population. So it's a much more stronger predictive in the non-cancer population. That may relate to the competing risk of cancer mortality. Okay. We know that certainly for observational data sets so in randomized controlled trials, we know that giving primary prevention aspirin to even high risk groups is not really associated with benefit, and there is an increased risk of bleeding. Even in diabetics, we know that we have randomized controlled trials. There is increasing data, though, that says that perhaps we should be focusing in the high-risk population as defined by CAC score. My only concern with that, which you touched on, is the bleeding risk of the population. So I would say, and again, this is not evidence-based, this is just what my sort of understanding of the data or sort of extrapolating data, is that in those where there isn't a big bleeding risk, so for example, breast cancer patients, prostate cancer, I probably would use it in the high CAC group. In terms of those with gastric cancers, colon, GI, I would feel pretty uncomfortable in those groups. Now, in terms of statin use, we've actually done some analysis on primary and secondary prevention. And actually, in terms of statin use, and actually, cancer patients get better primary and secondary prevention in terms of prescription of a statin than non-cancer patients, which surprised me. And I guess that's at least something that made me happy, in the sense that we are recognizing that these patients are at increased risk of cardiovascular events. Oh, drug codes, there's another message.
I can read out that question
yeah.
the rest of the audience, Dr. Mama. So one of my co-fellows, Sergey, he asked, what are your thoughts on the use of drug-coated balloons as a developing technology in potentially reducing the outcomes gap in this high bleeding risk population?
So I guess drug-coated balloons, so I had a debate about, I think it was in the Cardiac Society of Mexico last year, and that was one of my end slides where I said, we need to have more data of drug-coated balloons in this population. And I think that's a really good strategy, particularly in the very high bleeding risk patients, because of course, all these trials that have looked at antiplatelet regimes, long versus short, depend on the patient not having an event in the first 30 days. And you randomize at 30 days when the patient's been event-free to whether you continue antiplatelets or stop it. Well, what happened? You don't know that at the time of doing a PCI. I don't know whether, in my pancreatic cancer patient that I didn't know who's going to have a massive GI bleed that night. You don't know. And so I would argue that in cases where you really are worried, like the active colon cancer cases that haven't had surgery yet, awaiting surgery, actually it would be a really smart move to use a drug-coated balloon, because then, if you have to reduce your antiplatelet therapy or stop it, there's not as much of a concern because you don't have a metal scaffold that's been left behind, and you don't have the risk of stent thrombosis. I guess then intravascular imaging is very important, because then if you do a drug-coated balloon, then you need to make sure that your result is good. And there are certain criteria that we use for drug-coated balloons. So it's not something that I've seen huge amount of data in, particularly, or any data for the cancer population. But I think it's the direction of travel for certain cancer subgroups. And it's certainly something that I've adopted in my practice in the ones that I'm really worried that they're going to have a bleed in the first 30 days. Then I'll just use a drug-coated balloon in those cases. And we have data from ACS. So we published a paper in JACC Interventions, not in high bleeding risk, but overall ACS patients, propensity score match analysis, over 1,000 patients with significant numbers, I think 600 in each arm of drug-coated versus regular stents. And actually, for the hard endpoints, there was no significant difference up to 1 year in this population, but this is not high bleeding risk or cancer patients. So I think you wouldn't be criticized in taking that approach, and I think it's a reasonable approach.
Sounds good. We have another question from one of our cardiology attendings, Dr. Chakrin, who says, excellent talk, thank you. Can you please broadly speak about your personal experience with patients receiving immune checkpoint inhibitors and the accelerated atherosclerosis that may be seen? Are there any differences if occurring lesions that you see during PCI? Is there any difference also in the risk of thrombotic events post-PCI in this population?
So again, superb question. And I would turn to data that I've seen that's recently been published, that one of my friends in China has recorded, Haibo. And what the Chinese are great in the sense that they have these huge centres, with 10,000 PCIs a year. It's something that to give that as a way of context. We do about the highest volume centre in the UK is I think 2,500 PCIs. I think the US is about 3,500. No centre has 10,000. And the other great thing is they literally do OCT on every patient, and not only in his centre, Hybo Centre, not only in the target centre vessel, but also in the other vessels as well. So he showed me his data. Now, unfortunately, he didn't have data on the cancer therapy, so immune checkpoint inhibitors. I haven't got that data. I can only report what I've seen in a couple of cases, which isn't particularly scientific. But in terms of OCT findings in this cancer population, number one, these patients have much heavier plaque burden. Number two, they are much more likely to have thin cap fibroatheroma. And number three, there's a much higher rate of erosions in this population. Now, whether that's related to, drug effects, I'm not sure. But it seems to be that the rates of erosions are slightly higher than the non-cancer populations, and the rates of plaque rupture events are slightly lower. Like I said, I don't know whether that's related to the types of agents that we're using. I don't know. I don't know if Dr. Check-in, I hope I've pronounced your name correctly, has any views on that or what his experience would be. Is Dr. Check-in there?
I think he's there.
Thank you. I'm not an interventionalist. I'm a cardio-oncologist, but I do just find this very interesting. So I do appreciate your insight.
Okay, no, great. And do you come across quite a lot of patients with immune checkpoint inhibitors presenting with myocardial infarction in your practice?
Yeah, we have. We've published a few case reports with kind of rapidly accelerating atherosclerosis, patients that have either left heart cath and then shortly afterwards have ACS or have stress tests, and then shortly after starting immune checkpoint inhibitors have acute coronary syndrome. So I know it's an evolving field, and I think we focus a lot on myocarditis, but I think in the future that's going to be a much more relevant and important aspect when it comes to immune checkpoint inhibitors.
I agree. So handing back to you, Rahul.
Those are all excellent points. This is a fascinating field. I think we can only learn more with more studies in this field, and I think perfect area for research. Shannon just shared her screen for the CME code. In case anyone needs the CME code, text 29693-27824 to 804-625-4041. Do not forget the dash in the code, and the code expires in 7 days. Otherwise, if I don't see any more questions, it was a great presentation, Dr. Mamas. Thank you so much for joining us. We will see you again in the afternoon here for fellows meeting.
Great. Thank you. Nice to see you all. Thanks to Shannon for all her help. It's been superb, particularly the mild panic that we had with relation with the slides. So thank you.
No problem. It was great. Thank you.
All the best
to you.
Worked it
out.
Yep. Take care, everyone. Bye.
Right. Thank you so much.
One final comment. Dr. Naif Abuzaki from one of our former attendings, he says, "Thanks, Professor Mamas, for great talk."
Thank you.
Abuzaki.
No, thank you, Abuzaki. That's really kind of you. Thank you for joining us.
All right. Thank you, everyone.